Thank you all for attending our Autism 200 lecture tonight. It's my great pleasure to introduce Dr. Hao Kwan. Dr. Kwan is Associate Clinical Professor of Psychiatry at UW and attending psychiatrist at Seattle Children's Autism Center for past 10 years. Dr. Kwan received his psychiatry and child psychiatry training at UCLA and then NIMH-sponsored postdoctoral research fellowship at Stanford University. Dr. Kwan has very impressive scientific and clinical track records with a long list of publications, book chapters, and presentations for treatment interventions for children with autism and developmental disabilities. In addition to his affiliation with UW and Seattle Children's, Dr. Kwan has a long-standing private practice in East Side that is very well received by families and colleagues, as evidenced by his numerous awards, including Seattle's Top Doctor Award in Child and Adolescent Psychiatry by Seattle Magazine for several years in a row from 2010 to 2018. Amongst our own colleagues and staff, Dr. Kwan is highly admired for his professionalism, intelligence, efficiency, as well as his commitment to our patients and families. Tonight, Dr. Kwan will present perspectives on psychiatric treatment of autism spectrum disorder, followed by our Q&A sessions with our faculty panelists, Drs. Borkenek, Kamenish, and Russell. Without further ado, please join me in welcome to Dr. Kwan.
Thank you, Sue, for that very nice introduction. It's a pleasure to be here with you tonight and with the folks online. What I wanted to do today was to talk about how we try to treat conditions on the autism spectrum from the psychiatric perspective. Psychiatric perspective means that overall, it's a pretty narrow range of treatments that we can provide for our individuals with autism spectrum disorder. And so we can give you our the small part that we can play in the overall treatment of our kids with autism. I think that overall, I would say that being a physician in this field is pretty humbling because it's not the same as being the center of attention in some of these other fields. So as a psychiatrist, we feel that there is some small role that we can play, but that has to exist within the context of this much larger team that always has to be in place. So let's get started. I first wanted to talk to you about the institution where I work, and it's a subsection of Seattle Children's Hospital. It's the Autism Center that's just down the street. It was formed about 11 years ago, and we had some of the major players here at Seattle Children's Hospital, as well as some of the people in the community, get together with this very strong drive to provide the goal of integrated approach to care. So that means it's not just a group of psychiatrists working or a group of psychologists working or behavior therapists. It's really trying to achieve the integrated care that we feel our kids really need. And to that effect, we have a multidisciplinary team at Children's Autism Center that includes these different disciplines. As you can see, there's a wide variety of different disciplines that are represented. It doesn't include everybody, and it also doesn't include some of the fields that are still required that we just simply haven't been able to incorporate into the Autism Center yet. All right. Now, some of the other things besides those medical disciplines that I listed before are that I think are key players in providing services are family resources and support team. We know how difficult it is to achieve anything in the field of autism treatment without understanding what all the resources are, because as you guys probably know, the requirements of our kids are vast. It's not just in medicine, it's not just in pediatrics, it's not just with a psychologist, but it requires all these different areas. And fortunately, we have the help of people on our family resources and support team, incredibly helpful for us as well in communicating with our families. An additional really helpful part of what we can do at the Children's Autism Center is that we can integrate with research teams. So people who are the researchers here at Children's Hospital who are pursuing clinical or more basic science research to be able to have access to them, and for them to be able to have access to the clinical services and patients of Autism Center has been a very nice reciprocal relationship. I wrote coming soon. I wasn't sure if this is actually the case. Is it coming soon? It hasn't been. Yeah, hoping for the summer. So another incredibly important part of treatment is treatment of people beyond the age of 18, because we know that it doesn't go away at age 18. Gary Stobie, who was one of the people who headed the founding of the clinic, has a special interest in working with adults, and he's heading the Adult Autism Transitional Services, and again, we hope to have these sorts of services available to us in the next year or so. All right, so jumping into talking about the conditions. So I think we're all familiar with the core symptoms of autism spectrum disorder. And here I have 2 bullet points. Prior to about 5 years ago, we used to have 3 bullet points. We used to separate social function and communication, but now that's sort of been collapsed into social/communication deficits. And then we still have the restricted repetitive interests or behaviors. So we talk about these core symptoms because these are really what separates our kids with autism from kids with other conditions. And so this is going to be pretty important to think about when we think about what sort of treatments we as psychiatrists can provide. So an important question is, are those core symptoms that I just talked about, are those core symptoms of ASD appropriate targets for medication treatment? Can we do something about the social functioning? Can we do something about communication delay? Can we do something about hypo or hypersensitivity to sensations, repetitive interests? So the answer, I think we as psychiatrists sort of know, is that the answer is no. We really can't. We don't have really terrific ways to try to address those core symptoms. So I wrote here that the core symptoms generally are not good targets for use of psychiatric medications. So that, of course, that's incredibly frustrating to all of us that we can't, provide a medicine that helps with those core symptoms. But that, unfortunately, is the state of affairs. I wrote generally because there are some exceptions that I'll talk about a little bit later that can include some repetitive behaviors and inflexibility or rigidity that might be somewhat responsive to medications. We'll also talk about some experimental medicines that might help with some of the social aspects of functioning. One of the major concerns that come up when we're thinking about treating these core symptoms is that we still have an extremely limited understanding about the neurobiology of autism. So even after, I've been in the field for over 2 decades, and we were quite hopeful 20 years ago about shedding some light on the condition, but in spite of that hope, we're still pretty limited right now in terms of what exactly is going on in the brain that results in the symptoms of autism. So when you've got that limitation in understanding what the causes of the condition are, of course, you're going to have a harder time trying to address that. Now, this is similar to what happens with a lot of other psychiatric conditions. For depression, for example, or bipolar disorder, schizophrenia, there is still a great deal that we don't know about what goes on in the brain that results in those symptoms. We might have some better ideas about some of the neurotransmitters that are involved in depression or OCD or ADHD, but we still have so much to learn that we just don't have the capacity to be able to target those underlying causes of autism. And one comparison that I frequently make is that this is, it's very different from other conditions where we do know the biological underpinnings. And so here we're talking about some other conditions, let's say for diabetes. Diabetes, the exact cause may still be a little bit murky. We think there's autoimmune components, there's genetic components, but we know what the problem is. We know that insulin is not being produced by the pancreas. And so if we know that, what we call the pathophysiology, or what's wrong with the body, we have the ability to sort of have targeted treatments. So if you know what the problem is, then you have a much better chance of trying to address it. And unfortunately with autism, that's not the case. Now, the other point that I would make is that even with better understanding, what's happening in the brain is so incredibly complex that even with some better understanding, it may not be possible to reverse some of those underlying conditions or core symptoms of autism. So one example that I think about is Fragile X syndrome. Fragile X syndrome is a single gene disorder that results in intellectual disability. So it's the most common genetically mediated cause of intellectual disability or mental retardation in the world. Now, in contrast to autism, we know exactly what the problem is with Fragile X. It's a single gene that just gets switched off on the X chromosome. But that single gene, what happens is that if you don't have that protein being produced by that single gene, it leads to a whole range of different problems that include brain formation, but also includes other organs in the body as well. So even in that case where we do know what the genetic cause is, it would be pretty hard to try to correct those symptoms in somebody who's 5 or 10 or 15 years old, because they've gone through 5, 10, 15 years of brain development, and you're not going to reverse that just by giving them that replacement protein. So because of that complexity, it's not as simple as just replacing something that's missing. So the overall message is that it's pretty hard to try to address those core symptoms, at least with what we understand right now. Now, I think we also all know that in addition to those core symptoms, there are a whole host of associated symptoms, and these include the ones that I list here. These are probably the most common ones. Insomnia is incredibly common in our kids with autism. ADHD is likely occurring in more than 50%. Self-injurious behaviors, aggressions, tantrums, very common, very disabling, just an incredible drain on the systems of people trying to support our patients. Depressed or unstable mood is also pretty darn common as well, and we think that increases as kids get older. Anxiety seems to occur just across the age range of our kids with autism, and we can think about situations that might trigger anxiety, like social situations or sensory overload situations, but there also seems to be some genetic predisposition to increased risk for other conditions as well, including OCD, panic disorder, and then obsessive-compulsive or repetitive behaviors. This is where we see some of the overlap between those core symptoms of rigidity and repetitive symptoms and other conditions like OCD. So, unfortunately, having autism doesn't free you from having other psychiatric conditions. In fact, it's the opposite. If you got autism, you're more at risk for having these associated conditions than in the general population. So I always tell people to think about comorbidity or conditions occurring together as the norm rather than the exception. I think the only silver lining to that fact is that with these associated symptoms that I'm listing here, as well as some other ones, they are more treatable than those core symptoms of autism. So, in fact, these will be the target symptoms that we as psychiatrists will try to help with. So what are the factors in thinking about whether to consult a psychiatrist? I'll tell you that at this point, in most cases, families might be having diagnoses made by a psychologist or psychiatrist or speech and language therapist, but a psychiatrist may not necessarily be one of the primary people at the beginning of this process. So when do you decide to consult a psychiatrist? Of course, it's not just the family decision. Hopefully you get some aid from other professionals in making that determination. But these are the things that I'd hope that you guys would think about. First of all, are the target symptoms that we're trying to deal with, are they going to be responsive to medications? So that may be one of the most important questions. Again, if we're dealing with core symptoms, let's say of social skills or language impairment, those are generally not going to be responsive to medicine. So it may not really be worthwhile at that point to be talking with a psychiatrist. Have non-medication options been tried? So this is even true for those associated symptoms I mentioned before that could be responsive to medications. We still want to pursue non-medication options. And this is true for people with autism and people without autism. So if you've got anxiety disorder, you want to take a look at whether it makes sense to try various therapies: behavior therapy, cognitive behavior therapy, play therapy, group therapy. So these different options exist for other conditions, and when the symptoms are on the mild to moderate range, we typically want to try these non-medication options before moving on to medications. And related to that, how severe are the symptoms and what is their effect on functioning? Again, if we're thinking that the symptoms are not as severe, if they're on the milder side, we probably want to think about non-medication options for treatment. We might even, we might even think about not doing anything. And the classic example of that is with tic disorders. So tics can bother parents a whole lot. They're tremendously anxiety-provoking for parents, but how much is it interfering with functioning? That's the question that I ask parents to think about, and for the patient to think about. If they're having tics, but it's not getting in the way of school, it's not getting in the way of social functioning, we often do nothing. So we think about whether it's getting in the way. Because when we think about medicines for tics, oftentimes the treatment is worse than the symptom itself. So think about overall effect on functioning. And then this last point that I think is worthwhile for us to think about is kids may have been tried on medicines before. Have previous trials been ineffective for whatever reason? What I find is that this is true for, I think, any of us working with kids, is that it's pretty neat to watch them grow up. And part of the growing up is that they go through tremendous amounts of change, including neurobiological change. That change will also make a difference in how they respond to medicines. So frequently I will see kids at 10 or 15 or older who may respond very differently to medications than they did when they were younger. So because they tried Prozac or Zoloft when they were 7, and if it didn't work back then, it does not mean that you should never try it again. If they tried stimulants before and they didn't eat very well and you had to stop the medicine, it does not mean that you can't try it again when they're 12 or 15, when they're bigger and they're probably better able to manage their appetite. So think about whether it's worth trying again. So if you get to the point where you do want to proceed with a psychiatric evaluation, this is what we typically do. So this is a rough guideline as to what we do during a psychiatric evaluation. Generally I'm hoping that people go to a psychiatrist and they don't just say, I have ADHD, and then you get handed a prescription for a stimulant. Hopefully that's not the case. So what we as psychiatrists hope to do is that we want to make sure we're seeing what we're diagnosing accurately what we're seeing, that we don't just take the word of the concerns or diagnoses that were given to us before, and we want to make sure that other factors are not interfering with the symptoms, contributing to the symptoms, or masquerading as other symptoms. ADHD is a classic example. So, kids, teachers or relatives might say that's ADHD, but when you really look at it, when you go through this process, we need to take a look at whether anxiety, depression, learning issues might be contributing to their presentation, and that mimics ADHD rather than actually being ADHD. So if you treat a kid with anxiety disorder with stimulants, ADHD medicines, that is not a good thing. So you're actually going to make the anxiety worse potentially. So that's why it's important to go through this pretty thorough process. The other thing that I want you to take away from this slide is that when we take a look at this, there's typically not a whole lot of lab testing or imaging. What I think people really want is they want like hardcore data. They want pictures from scans that will tell us what's going on. And unfortunately, in the field of psychiatry with these conditions that we're dealing with, those things don't help very much. We want to make sure that there are no medical problems like thyroid conditions or other things. But for the most part, the way that we determine psychiatric diagnoses is by talking with people. So we talk with parents, we talk with the child, we do observations of the child. Hopefully we'll be able to talk with teachers, we talk with other clinicians. So those are talking, believe it or not, is the state of the art in psychiatry. All right. So general strategies for use of medications in kids. This first point I think is critical. We want to clearly identify the target symptoms that we're looking for or that we're trying to treat. We don't say, let's try this medicine and see if things get better. That is too generic, too nonspecific, and I think that will lead to overuse of medications and needless side effects. So identify the target symptoms that we're really trying to monitor and that we can really sort of sink our teeth into when we discuss it at follow-up. Now again, this is not something that you can do a blood test for, but I think overall the families and children and teachers can do a pretty good job in giving us some meaningful feedback about how things are going. That could be in the form of the narrative discussion that we have in the appointments. It can occur through the form of questionnaires that we ask teachers and parents to fill out. And as crude as this sounds, just using a 0 to 10 scale actually is very helpful. So you ask the patients to describe anxiety on a scale of 0 to 10. They're pretty good. I'm really impressed at how consistent those numbers are. So the only difference would be that Zoran's 4 may not be the same as Sue's 4, but Zoran's 4 is probably going to be the same 4 that he means in 2 months from now. So within that person, they're pretty accurate in being able to give us a good idea about what their level of symptomatology is. And then we discuss various options in choosing the medication class. What you'll see when I start talking about more specific medications is that, frankly, we don't have a whole lot of tools to use. We've got maybe, we just have like a handful of classes of medicines to use. Now, within each class, there are multiple medicines, but we're simply just not dealing with a whole lot of medicines. But it's going to require a lot of consideration between the clinician, the patient, and the parents, as well as other clinicians who are involved in care to figure out what it is that's going to be most likely to work. And the balance or the scales that I ask people to consider all the time is how much do we think this is going to help? So the possibility of benefit versus the possibility of side effects. This is the weighing and the balancing that we're doing constantly. So if you think about those measures, I think that gives us a lot of information about whether we want to try pursuing the use of any of these medicines. So how well is it going to work? And the corollary of that is how bad are those symptoms that you're having right now? Could there be huge benefit if we get those symptoms under better control? And then how serious are those side effects? And we'll talk about specific balances with different medicines. And then, unfortunately, this is true for child psychiatry across the board, but doubly so for our patients with autism, is that they typically have a higher incidence of side effects and lower incidence of effectiveness compared to patients without autism. So stimulants are a classic example. Stimulants work really well for ADHD, but it seems that our kids with autism with ADHD that we're using the medicine for the correct reason, they're more likely to have to stop the medicine because of side effects, and it probably doesn't work as well in those kids as in kids without autism. So that seems to be the case really just across the board with all these psychiatric medicines. All right, so another strategy that I really feel is necessary is you got to get the patient and the family on board. So that means there's got to be some general agreement that we want to proceed with this treatment. I tell parents that I don't take any of these medications lightly. We can use the mildest psychiatric medication that we have, but this is still a very serious decision to pursue. We'll talk about the developmental consequences of these medications, but we simply can't go into this process sort of uncertain about whether we want to proceed. So we really have to feel like there's a need to proceed with this step. If you don't get the patient on board, it's pretty tough. Unless they're very young and they don't know what's going on. If the patient is resistant or not in agreement with this treatment or doesn't feel that they need treatment, it's pretty challenging. So it's pretty important to take that step. I generally want to make one medication change at a time. So that's for the simple reason that if you do two things at once, you're not going to know what caused the benefit or the problem. You can... So ideally, we do one thing at a time. So that's what I tell patients and families. We want to know what's doing what. There are clearly circumstances in which we can't do this. So there are clearly circumstances in which we feel like there's significant side effect with one particular medicine that they're taking, and yet we really feel a strong need to get another medicine on board, and so we might make those changes simultaneously. We also make changes simultaneously when we're tapering down on one medicine and going up on another. And so what I tell families is that, if this were a science experiment, I think if those of you who've done science experiments know you want to try to change one variable at a time, so you know what the result is. If this were a nice little science experiment with plants, you can do it. You've got the luxury of time to be able to make one change at a time. But we know that in clinical situations, that's not the case always. But generally, we really want to try to do this. Start low, go slow. This applies to young kids and applies to older patients, to the geriatric population. We generally, my strategy is always to try with the smallest dose that's possible, and then progress pretty slowly. The exception there would be if there were some very urgent situations going on. So if there is a danger to self or danger to others, we might think about raising things more rapidly. On the inpatient setting, I think the doctors there would tell you that they don't have the luxury of being able to do that necessarily. But overall, this is a really important tenet for me to stick by, because I think it reduces the likelihood of side effects. And if side effects happen, you're going to lose the patient. They're just not going to agree to continue taking the medicine. So that also allows us to really sort of hone in on the smallest effective dose. So go slow also is important, because these psychiatric medications often take weeks to work. So if you're impatient and you wait just a few days and you start escalating the dosage, that doesn't really make sense with how these medicines work. Similarly, use the medicine for an appropriate duration before abandoning. So in certain situations, I've seen medicines change rapidly, one after another. It might be because of side effects. It might be because the symptoms are spinning out of control. But again, that's not the way that most of these psychiatric medicines work. Stimulants can work very quickly. So you might know in a couple of days if the stimulant works. But for most other medicines, antipsychotics, antidepressants, even guanfacine, which works a little bit faster, you're talking about weeks before you really know whether a particular dose works. And then the other principle that I tell families about is that if one medicine in a class doesn't work, it's okay and perfectly reasonable to try another one. So SSRIs, these antidepressants, if you try Prozac and it doesn't work, it doesn't mean that all the SSRIs are swept off the table. It's perfectly reasonable to try Lexapro or Zoloft. Okay? And there are plenty of people who do well with one medicine after not having done well with one of the others in the same class. If you look at a lot of these medicines within the same class, if you treated 100 people with the condition, roughly the same percentage of people would respond. So we don't think that Prozac is spectacularly better than Lexapro, but for individuals, they may do a whole lot better with one compared to the other. This last one is pretty important for our kids with autism. We want to consider the preparation of the medications. So with younger kids, what can they swallow? Can they swallow pills? Can they swallow with a lot of the long-acting stimulants? They come in capsule form, and the kids don't. A lot of the younger kids don't like or can't swallow capsules. So if that's the case, can you actually take this capsule apart? If you do take it apart, can they chew it, or are they not allowed to chew the contents? So all those questions are pretty important. A lot of the medicines come in liquid, which you think would be convenient, but they don't like the taste. So all these considerations are important. Okay, so those are the strategies. And then when we're thinking about these psychiatric medications, an important question is we're hoping that they help. We're hoping that they help with those target symptoms. But what might be the consequences of these medicines on brain development? And most of the studies that are done for adults as well as for kids, they're very short. They might be 6 to 8 to 12 weeks if we're very lucky. but that doesn't tell us what it does on a long-term basis. So the answer to this is that we don't know. We don't know what the long-term effects are on brain development. We can think about these different medicines that have been out for decades. Prozac's been out for 32 years. Lithium's been out for decades longer. Stimulants have been out for decades longer. So in that sense, we do have some idea about brain development in that we don't think that these medicines derail brain development or cause major damages in brain development. So, and we can say that because we're using the empirical evidence or the practical evidence of having treated these patients for years. So Prozac's been out for 32 years. There are some people out there who've been on Prozac for 32 years. So based upon those folks and people who've been on medicines for 10 or 20 years, we can say that from what we can tell, 10 or 20 years later, we don't see any substantial impairment in different aspects of brain functioning. Okay, so I think even though a study to look at whether Prozac affects brain development would essentially be impossible to run because you'd have to recruit patients and have them on these studies for 30 years and compare them to patients off the medicines. Those are not feasible. From the empirical evidence, we're feeling reasonably comfortable that it doesn't have negative effects on brain development. I would also say that there is some growing evidence that these medications can have protective effects on neurodevelopment. So we think that lithium can have some protective effect on brain tissue. And there's some preliminary evidence in bipolar disorder and schizophrenia about medications, when they're being used appropriately and effectively, having some protective effect and preserving brain tissue. So those two facts help me sleep a little bit better at night in prescribing these medicines. Okay, so let's dive into these different medication classes. You guys have probably heard about a lot of these, and so I'm going to go relatively quickly through it. I'm going to go quickly, so if you do have some questions, feel free to jump in if you want me to specify something. But these are the major, I told you there was sort of a handful of medication classes. We don't have a huge number of classes, but these are the major psychiatric medication classes that we use. And I wanted to just give you an example of a patient that I treated a number of years back, Michael, age 7. His presentation is what I think is not that different from presentations that I see all the time at the Autism Center and in my private practice, which means that things are pretty complicated for our kids. So he was diagnosed with autism spectrum disorder, but he's got a whole host of other symptoms as well: anxiety, mood issues, aggression. He's pretty young, so I don't believe that it happened at school yet, but that would be the big concern, that as he gets bigger and as things might get frustrating for him, that these problems are then going to spread into the school setting as well. Hyperactivity, oppositionality. So in the previous year, these symptoms had been getting worse. We might think about whether school and the academic demands of first or second grade might be contributing to that. But there seemed to be some crescendoing of all these symptoms over time. His parents had tried a whole host of different therapies. Some of these are a little bit older. It tells you how old this patient is. But he underwent the DAN protocol. This harkens back to this type of therapy that tried to take a look at supplements and dietary changes. Handel Institute is still pretty active, and they work on sensory hypersensitivity through occupational therapy, and he's tried a bunch of other things as well. He's tried a whole bunch of different medicines too. So various clinicians had helped him try all these different medicines with variable effectiveness. So again, not that different from what we see in a lot of our patients at the Autism Center. Antidepressants are probably one of the more widely used medications for kids with Autism Center, and that may or may not be justified because the data are not that great, but we still use them an awful lot. The major classes are the SSRIs, which include Prozac, Zoloft, Celexa. SNRIs are a little bit more recent, and they include Effexor and Cymbalta, or duloxetine. And then we have sort of some of the more medicines that fall outside of those categories. We have some older medicines too, like tricyclics that I don't use a whole lot of in our folks with autism. SSRIs are clearly the most widely used antidepressants. I'm sorry, let me go back. So, they've all been around long enough so they're all available in generic form. So that's one of the nice things. They're cheap and they're easy to get a hold of. Target symptoms, as you would expect: depressed mood, anxiety, irritability. And I wrote rigidity and repetitive behaviors. Now, I took a look at the research, and the research is just disappointing, because if you look at these symptoms, rigidity and repetitive behaviors are part of the core symptoms of autism. So, you keep your fingers crossed and you hope that it might help with these core symptoms. But unfortunately, the research is telling us that these medicines don't work that great for rigidity and repetitive behaviors. They work slightly better in adults than they do for kids with autism. But clearly for depressed mood, anxiety, irritability, these are reasonable choices and reasonable targets symptoms. So again, evidence of effectiveness: fluoxetine and citalopram, some larger studies, kind of disappointing when we take a look at those core symptoms and in the autism population in general. Citalopram, that was a medicine that I used all the time 10, 20 years ago. And then Brian King came out with a large study that taking a look at the effectiveness in kids with autism, and it was largely negative, meaning that it just didn't do a whole lot to treat those target symptoms. Now, the SSRIs, we still use them an awful lot for anxiety and depression. I think it's perfectly reasonable to use them for those indications. The side effect profile overall, I think, is quite favorable. And this was especially true when you compare them to the older antidepressants like tricyclics, which had a whole range of side effects some of which were just awful. So compared to those older medicines, the SSRIs were lifesavers when they came out. But they can still cause some nuisance side effects. They can definitely cause some sleep disturbances. Some of the SSRIs can make you very sleepy and sedated. Others can cause the opposite. So even though we're trying to treat anxiety and irritability, these medicines can cause anxiety and irritability as possible side effects. So, but fortunately, I found that if it does cause anxiety and irritability, it's often at the beginning of treatment, and then as the good effects of the medicine start kicking in a few weeks later, it often gets better with time. The biggest concern is highlighted in yellow there at the bottom: self-injurious behaviors and suicidality. So this was a concern that really came to the fore about 15 to 20 years ago, about growing concerns that in the pediatric population and the young adult population, that these antidepressants might actually cause depression, and then in severe forms cause self-injurious behaviors and cause people to have thoughts about wanting to hurt themselves. So what was done was that Columbia University was contracted to do a meta-analysis, which means to take a look at all the previous studies up to that point in the pediatric population, and to take a look at what the risks were. Is there, in fact, increased risk for self-injurious behaviors, worsening depression? And the answer was yes. So when they compared, when they looked at all those previous studies and they aggregated all the data, and there was something like 6,000 or 7,000 patients altogether in all those different studies, they found that in the people who were treated with the active medicine, there were probably about 2 to 3% of people who then experienced that severe side effect of suicidality, worsening depression, self-injurious behaviors. So that's the active arm, the people who got the active medicine. The placebo arm was about 1%, or 1 to 2%. So it was a statistically significant difference, 3% versus 1 to 2%. And I guess it sort of depends on how you spin it. So one person might say the antidepressant doubles the risk of suicidality, which sounds really scary. And another person might spin it and say it increases by 1 to 2%, which sounds less scary. Both people are correct, but it sort of depends on how you look at it. Overall, I felt in my practice that 1 to 2% increased risk of that side effect is generally worth taking, that risk. But again, you have to look at that potential benefit versus potential side effect. So this is a good example. The potential benefits of helping somebody with depression or anxiety could be tremendous. relieve depression, relieve anxiety, allow them their functioning to improve substantially. The potential side effect is devastating, to have worsening depression and self-injurious behaviors. So, but then you also have to take into account the likelihood that this is going to happen. So the likelihood of these good effects might be 50 to 60%, which don't sound that great, but it's better than doing nothing. And the likelihood of those serious negative effects is let's say 3%. So 50 versus 3%, in my mind, that balance is still favorable. So that's an example of sort of the thought process that I go through, weighing the risks and benefits. These are various other antidepressants. I'm not going to talk about them in great depth. Trazodone is an antidepressant that's not really used for depression anymore, but is used for sleep and can be very useful in that regard. Mirtazapine can be used for depression, also very helpful for sleep, and also for kids who are not eating or losing weight. Venlafaxine and duloxetine are the SNRIs, which you often turn to after I've tried a couple of SSRIs and if they haven't worked. So they've been very helpful. The antipsychotic medications, so these are the medicines that probably have the most research behind them in actually working in our kids with autism. So they've got the top two listed there, risperidone and aripiprazole, have been approved by the FDA and for use in children with autism. And I think we'll talk a little bit more later about what FDA approval means versus just a doctor prescribing it for whatever reason. Now, FDA approval is great, but I also use those other medicines as well. Risperidone, I find, causes a lot of weight gain and can cause galactorrhea and some other side effects which are not great, and so therefore I use aripiprazole a lot, and then I use some of the other medicines as well, probably more commonly than I do with risperidone. What are we using these medicines for? We call them antipsychotics because they were originally developed for help in with psychotic symptoms in people with schizophrenia. But we know that most of our kids with autism don't have psychotic symptoms. So I got to tell people your child is not psychotic. I'm not using it because they have psychosis, but because of these other benefits that they can have. So aggression and self-injurious behaviors, severe agitation, irritability, those are the major target symptoms for these antipsychotic medicines. There's some evidence that can help with anxiety as well, but I think, to me, it's a little bit too big of a gun to use for a symptom like anxiety, at least initially. It's also been shown that it can help with stereotyped repetitive behaviors or speech. Again, I feel a little bit hesitant to use it as a first-line agent for that kind of symptom because of the significance of the side effects. So the good thing about antipsychotics is that they have a healthy chunk of research behind them. They've been used for many years for those sorts of target symptoms in our folks with autism, and they've been approved by the FDA. The downside, so we have evidence of effectiveness through research studies over the years for these three medicines in particular. The downside is this slide here, is the side effect profile of these medicines. So these side effects are a lot more serious than the side effects of antidepressants. So that's what makes me reluctant to use these medicines as a first-line agent for these symptoms. So with a child who is severely irritable and may have agitation, I might use an antidepressant before using an antipsychotic medicine, even though the likelihood of benefit with an antidepressant might be less than that with an antipsychotic medicine. Side effects can include sedation, which can sometimes be helpful at night. A significant increase in appetite and weight. This is a very common problem with these antipsychotic medicines. That's one of the reasons I don't like using risperidone or olanzapine first. They seem to cause metabolic changes, so it's not just taking in more, but it's also you're not burning the calories as quickly as you typically would, and so that can often lead to elevation in cholesterol and blood sugar levels. So the risk of diabetes, that's a pretty darn serious concern. Extrapyramidal symptoms are symptoms related to muscles, so they can often cause muscle stiffness or other forms of discomfort. Anticholinergic symptoms are things like dry mouth, constipation, urinary retention, blurry vision. Not a lot of fun. The last two are the serious side effects of these antipsychotics. I mean, the other ones were pretty serious too, but the last two are what often scare me and scare the parents when we talk about it. Tardive dyskinesia is a side effect that's particularly problematic because in some people it doesn't go away even when you stop the medicine. So this is a condition that often involves the mouth and the tongue. It may involve other parts of the body too, but it's an involuntary motion, slower than a tic, so it's not as quick and jerky as a tic, but can often look like you got something in your mouth or you're chewing something. It's usually not medically disabling, so it typically doesn't interfere with chewing or swallowing or breathing. But the problem is that it may be irreversible. So even though it might be simply a cosmetic issue, people don't like hearing that a side effect might be permanent, even if you stop the medicine. So that's a very serious side effect. Neuroleptic malignant syndrome is also another very serious side effect. This is one that can occur suddenly, usually occurs more commonly within the first year of treatment, and usually occurs in people who have medical problems or in the elderly. So, I'd like to think that our younger, healthier patients are a little bit less at risk. But the parents and the patients still have to know about this because this is a life-threatening emergent side effect. So this involves very high temperatures, very stiff muscles, like lead, we call it lead pipe stiffness, and then confusion. And then if you check vital signs, there's instability of vital signs too. So this is a life-threatening situation. Not that common, but you have to know about it before starting this medicine. If I tell parents, if you see even one of those symptoms, very high temperature means not like 100 or 101 with a cold. We're talking about 103, 4, 5, 6, 7. So if you see one of these symptoms, you got to go to the ER and get this treated. Alpha agonists, these are medicines that guanfacine especially is one that I've used a fair amount because of this benefit to risk ratio. The good part of these medicines is that the benefits are okay. They're they're sometimes pretty good, but the risks are also pretty low. So we often use this for situations in which somebody is either hyperactive or agitated or engaging in really disruptive behaviors, but that this might be a milder option even compared to the stimulants. Okay. So typically used for hyperactivity, impulsivity, aggression, other sorts of disorganized or disruptive behaviors. Guanfacine, the long-acting guanfacine, which is called Intuniv, has actually been approved by the FDA for ADHD, but I don't think it works that great for attention, much more so for the hyperactivity and impulsivity. And here I list the side effects. It can also make people very sleepy, so for insomnia, clonidine is often used to just get them pretty tired at night. Somnolence is a side effect, fatigue, irritability, hypotension. So these medicines were actually developed initially to help reduce blood pressure, and then they found out that it has these other benefits as well. So hypotension or low blood pressure can occur, but I've found that in our kids, again, healthier with more resilient cardiovascular profiles, they typically don't experience a huge amount of hypotension. We do have to use them carefully if we're using stimulants as well, because both of these medicine classes can affect the cardiovascular system. If I use one of these classes by itself, I typically don't get an EKG if they're otherwise healthy. But if I use them together, I get a little bit more conservative, and I typically will get an EKG beforehand and afterwards to check the cardiac conduction. Stimulants are another really important class of medications, and we use stimulants in our kids with autism for the exact same reason that we use in kids without autism. It's for attention, focus, improvement from distractibility, as well as hyperactivity, impulsivity. Okay, and these are some of the major medicine stimulant classes. We are typically using longer-acting formulations of these medicines. So the older ones that I list here, the old ones last about 3 to 4 hours on average. So that's, gets you through half a school day. It's not super helpful for most of our kids. So the drug companies naturally have created these longer-acting formulations, which will hopefully get us through the school day, may even get us into the later afternoon and evening if we're really lucky. They've come out with some interesting medicines like Vyvanse and Daytrana, which is essentially Ritalin in a patch form. So those two, I think, last the longest and can be very helpful, especially for older patients. We talked about target symptoms. Side effects, it's the same list of side effects that we would see in kids without autism, but our kids with autism are going to be more susceptible to these side effects. So loss of appetite, insomnia are the two most common reasons that I've had run into for stopping these stimulants. And it's true for our kids with autism too. So loss of appetite. Loss of appetite, I believe, that's what leads to that last side effect of height suppression. Overall, I think that if people are eating okay and gaining weight okay, that the risk of height suppression is pretty minimal. So I'm not too concerned about that. Headache, stomachache, irritability, anxiety, tics. So tics can be worsened by these stimulants. The good thing about these stimulants is that if we run into anything that we really don't like, we stop the medicine, the side effects will go away pretty quickly. We do have some small cardiovascular concerns about these medicines. So to me, they are so infrequent that they're bordering on theoretical concerns. So at this point, there was a controversy a few years back between cardiologists and psychiatrists about whether we should get EKGs before we start stimulants. I think at this point, we are feeling like we don't need to do EKGs on our patients that we're starting stimulants on unless there is some family history of early cardiac death. So if there's that family history, get it, but otherwise we're going to be okay. Atomoxetine is a good medicine and was the first non-stimulant medicine approved for ADHD. It's not the only one right now. It doesn't seem to be as effective as the stimulants in the sense that it doesn't help as many people. So I think the stimulants probably work on 80 to 85% of people with ADHD. All of them can't stay on it because of side effects, but it's pretty effective. In my experience, atomoxetine is closer to about 50%, maybe even a little bit less. But if you're part of that 50% for whom it does work, it can be a great medicine. So it can help with attention, it can help with hyperactivity. And the other nice thing about Strattera is that if it works, it will work 24 hours a day. So that's a huge advantage over the stimulants. Sedation and gastrointestinal upset are the two most common side effects. Mood stabilizers. If we were talking about bipolar disorder, this is the same list of medicines that you'd see for a treatment of bipolar disorder. So these are the 4 major mood stabilizers. I haven't gone past this list. I just don't use those other anticonvulsants. I just don't find that to be very effective, and I find that these are more than enough. So we think about using these mood stabilizers in our kids with autism if they have any of these symptoms, manic and depressive symptoms, of course seizures. I say of course, but I should mention that valproate, carbamazepine, and lamotrigine are all anti-seizure medicines as well as being mood stabilizers. Lithium is not an anti-seizure medicine, but if you've got autism, you've got bipolar disorder, and plus you have a seizure disorder, it's nice to be able to use one of these mood stabilizers. Even if you don't have clear bipolar disorder with your autism, there are situations where I think these medicines can still be very helpful. And I know I've been using lithium more and more as time goes on to help with irritability, mood lability, impulsivity, aggression, self-injurious behaviors. So I think overall a very useful class of medications. The side effect profile is too long for me to get into right now because these medicines are also not that much fun to use because of the side effects. When I compare the side effects of these medicines with those of the antipsychotics, they're different. The side effects are clearly different, but they're often almost equally cumbersome to use antipsychotics versus these mood stabilizers. With the top 3, you got to get blood tests as well. And so if your child doesn't like blood tests, that's a problem. Lamotrigine doesn't require blood tests, but it requires months for you to get up to the dose because of this risk of rash. So clearly, side effects are limiting a factor in thinking about using these medicines more commonly. So I'm listing some other assorted agents here. Buspirone, which is an anti-anxiety medicine that helps some people with generalized anxiety. Propranolol can also be used for some different cases of anxiety. Amantadine is another study that our former director Brian King did a big study on. That came back negative, so whether it helped kids with autism. But it seems, on an anecdotal basis, I think it does seem to help some people with attention. It also is an appetite suppressant, so if you've got weight gain from antipsychotic medicines, this can be helpful in managing that appetite. The last one is a very intriguing medicine. It's an important medicine that we'll probably be hearing a lot more about in the next few years. Oxytocin is the hormone that's involved in contraction of the uterus during childbirth, and so it's a naturally occurring hormone, but it seems to have some pro-social effects. So that's what some of the preliminary studies had shown, that if you administer oxytocin to kids with Asperger or autism, that it can actually improve social functioning. So this is the one medicine that I wanted to mention that may actually help with those core symptoms of autism. So there's some indication that it can be helpful. Seattle Children's was part of a large oxytocin study that was done. I don't know if those results are out yet. Still analyzing the data? Yeah. So I actually had a couple of my clinical patients who participated in the study, and they felt that there were clear benefits. So I think we're all really quite excited to hear about what those results are going to be. It has not been approved for use in autism, of course, so it's still theoretical. I want to loop back to after hearing about all those different classes of medicine, I want to loop back to Michael. So these are some of the steps that we ended up taking after I assumed care. So we had to discontinue fluvoxamine because of concerns about bipolar disorder. We tried a different antipsychotic medicine in place of risperidone because risperidone caused a lot of weight gain, but aripiprazole just didn't work as well as risperidone. We tried valproate because of these concerns about bipolar disorder, but then he had serious side effects, and they got so bad that he had to go to the ER on a couple of occasions because of how bad these side effects were. In the ER, they tried some different medicines too. They tried old school chlorpromazine, which is an old antipsychotic medicine, and then lorazepam, which is very commonly used. Next, we tried lamotrigine, which is a mood stabilizer. That's the one that takes months to get up to it, and it just didn't provide a whole lot of benefit. And then we finally looped back to guanfacine, which provided some help with agitation. So, this, I wouldn't say that Michael's course is what you should expect if you're going to see a psychiatrist, but it, on the other hand, is not uncommon. It's not uncommon to go through a host of different classes of medicines, even for the same sort of, we're talking about irritability or agitation. We might try 3 or 4 different classes of medicine for that particular symptom. So, fortunately, at the end there, we found something that helped. We hope that it continues to help, but the process is not necessarily an easy process. Also, as you can see, it's not just the psychiatrist or nurse practitioner that's doing it. You got other clinicians involved as well. The ER was pitching in with attempts to help out. So, again, it's a fairly typical course for people with severe symptoms and complex courses of treatment. So, I'd end with these take-home points. Usually, there are no simple solutions. I think we'd be very lucky if a child comes to see me, and we were able to use one medicine, and we have a significant benefit from that first medicine. It's great when it happens. It's not the majority of cases, and so therefore, we should not go into this process thinking that it's going to be a simple process. I emphasize that multidisciplinary approach is the norm. I spend all my time here talking about the medicines for the most part, but that is just a small fraction of the totality of treatment that we were expecting our kids to pursue. So when we talked about therapy for anxiety versus jumping in with the medicine, even if we proceed with the medicine for anxiety, we want the child to get therapy as well. So we need to keep in mind those other therapies that we want to continue to encourage the patient and the parents to pursue in addition to medications. I mentioned this before, comorbidity is the norm rather than the exception in our kids with autism. We expect them to have symptoms that are not part of the core cluster of symptoms of autism. We must track target symptoms to assess effectiveness. So really have a very clear idea going into this process of what it is that you're trying to treat. Know what in your mind, and make sure that the doctor knows in their mind what they're trying to treat. That it's not just general well-being of the child, but rather we're doing it for irritability, we're doing it for anxiety, panic, attention. So make sure you know what you're trying to address. And then lastly, don't give up. Okay? As we discovered with Michael, you know, it wasn't the first medicine, it wasn't the second, it was I think the 13th or 14th. In spite of the difficulties, you know, we keep doing this because we think it does work. In spite of the research studies that can, you know, for me, it threw some cold water on my belief about how well these medicines worked. Even if they don't work as well as we want them to, we do think that they can help. So don't give up. All right. Well, thank you very much for your attention.
Hi, we had a few questions from our folks joining us on Facebook. Do we have time for a couple of questions now, or should we hold them?
Absolutely, and I would invite our panelists to join me up front.
So Colin has two questions. One, he says, relates to tricyclic depression meds, where side effects such as ringing in the ears, would this be more of a drawback to using a drug like that, such as Pamelor or nortriptyline, in cases where the child has sensory issues, such as sound processing disorders?
Well, I would say, David, you want to go ahead?
I think Dr. Kwan alluded to the fact that probably I think the majority of us do not use tricyclics very commonly. So it's getting into some territory that is not generally part of our practice. Certainly considering children's sensitivities when trying to determine the best fit in terms of medication is important. So if there are sensitivity issues, absolutely it's worth taking into consideration. And beyond that, again, I think if again, it's about identifying the target symptom and going with the more common treatments. And so I don't think I heard there what the specific target symptom is, but if it's anxiety or something along those lines, there are other options that hopefully would obviate the need to answer that question.
Now you may have already addressed this somewhat, but he had asked earlier, what would the incidence of effectiveness of psychotic meds being used with people, namely pediatric cases with autism being involved?
The question, let me see if
I
understand that.
think you might have addressed it with the section on antipsychotic meds that you had covered, the overview of that, but he had just asked that what would the incidence of effectiveness of psychotic meds be with a pediatric population with autism?
So I think if we're talking about the particular, and David just did this as well, so if we're talking about using it for the right reasons, and for antipsychotic medicines, we're talking about irritability, agitation, aggression. So those are the symptoms that were found to be effectively treated by these medicines in the research studies. So I don't remember the exact numbers, but clearly there was an improvement in the children with being treated with antipsychotic medicines compared to placebo. So there was a statistically significant, meaningful improvement.
Any questions from audience?
Well, I guess my question is regarding brain development, which you said there wasn't a lot of research on, but I have sort of an anecdote, so maybe I could throw that out there and get your reaction to it. So when my son was young, I was concerned about the brain development and the other side effects, and I sort of had an ambivalent or neutral attitude about medications, and I thought, well, if he's anxious and when he gets a bit older, if he's interested in it, then we'll pursue it. Because it's not addressing the core symptom, so it's sort of symptomatic or something like that. But then we were approached, we were in a public place, and my son does have some tics, so we were approached by a young man who was at the time he was 21 years old, and he wanted to talk about his medication that he was taking, and I won't say which one it was, but he was very excited about it, and the reason he wanted to speak to me was because he said, I wish I started taking this when I was 20, and I wish I started taking it when I was 13, because I feel like it's just that it's actually having positive effects on me. And he really strongly encouraged me to take a more aggressive approach, less conservative approach. So I took that to heart. It's just an anecdote, I guess, but how do you, I don't know, how do you all respond to that? I mean, if there's not a lot of research, what's your sort of gut feeling about that?
Well, yeah, maybe I can say something like that. I think that you say it's anecdote, but in some level you're really state of the art, because there isn't really much more research. It really comes down to your kind of personal family values. When do you think you're going to intervene? I think the possibly common trap is that you probably did not talk with that young man, exactly what type of symptoms he had when he was 13, how impairments was at that time, his relationship with his parents. But I think having that sense, like really how much you're impaired, how much is that really bothering you, or your son, because you're a proxy for him or your daughter, if you have a daughter. And then you kind of go from there, say like, what would I do if that was me or my child? And I think that there isn't really, at current state of the art, as Howard was saying, we don't have a test to tell you like, you go to see some other doctor and tell you, hey, you need to start taking this medicine because this is really going to change your life. Or if you're, you're having high blood pressure, you're at really high risk. Symptoms in autism are usually not like that. If they don't bother you or bother the environment, there isn't really that your doctor is going to be able to tell, well, this is really bad for you. So you kind of have to have that sense yourself, and that's change in different times. As Howard was telling, like, example was if medicine does not work when you're 7, it may work when you're 10. So because the symptoms may be different. So I think that you're, following your gut rightly, and I think you're really at state of the art with your responses.
Yeah, and as Zoran said, and by the way, my name's Doug Russell. I'm one of the psychiatrists at Seattle Children's. Along the lines of what Zoran said, there isn't sort of like a magic or a perfect window, right, of time when these medicines work the best. What we're really looking for is degree of impairment, right? If that shows up when the child is 5, if that shows up when the child is 13, if that shows up when the man or woman is 25, those are the times when we start to consider treatment for it. That said, in child psychiatry, there are some considerations in terms of timing that we're always thinking about. There are developmental windows where, a child, one of their tasks is to, in early childhood, is to find mastery in something, to instill some sense that they're good at something, right? And if you have a child, like, let's say a child who has ADHD, who's really struggling in class and just can't achieve that mastery, and you're noticing that, that's a good time to start thinking about treating it. Does that make sense?
I have one other comment about that, and I really appreciated the anecdote that you shared with us, because it points again to these developmental questions, because the kids are changing, and when you step in may be critical to certain parts of their development. The flip side of not knowing what the potential negative effects of these medicines are in development is that if you don't treat it, if you don't treat these symptoms, that's going to have a negative effect on development too. So if the child is subjecting or experiencing anxiety for years, that's going to get in the way of these incredibly important developmental processes that they should be experiencing. So that's something that I try to convey to parents as well when they're feeling kind of nervous about the medicine. They should be nervous, but the option of not treating these serious symptoms is not a great one either.
Hello. Thank you all for your time and information. Appreciate that. My son is 12 years old. He's been on stimulants for, I would say, the better part of 5 years now. Recently, we have seen increased signs of aggression, potential self-harm. And my question mainly lies in resource information, in the sense of he has been showing more of these signs, and I personally feel like he's due for a reevaluation of his stimulants, whether that is to take him off completely and try a different approach, or to change the type of stimulant that he is on. I was just curious what your guys' opinion would be on addressing that, or trying to engage a reevaluation for him.
I think you've kind of answered the question if you have a question about whether it's time to reevaluate things. I mean, it's a process. Our work is a process of constant reevaluation, and so we wouldn't deny that to you at any point when you are wondering if you're doing the right thing. As to how you might go about it, depending on who's prescribing the medication, well, regardless, I would start there. In some cases, that is something that can be explored with a primary care doctor who has sufficient experience and comfort with that. There's resources for them to seek guidance and consultation with a child psychiatrist much more quickly maybe than you might be able to get in to see one, have your son see one. But you can do both of those things at once. Talk to your pediatrician, have them initiate a conversation with the psychiatrist, maybe give them a next step or two, and then if they get stuck, perhaps have him in line already to see a specialist and go from there. But if it's on your mind, absolutely, it's time to check that out.
Yeah. And puberty can be a time of immense change for our folks on the spectrum, but also neurotypical individuals. So in the process of that reevaluation, I would encourage you to talk about sort of developmentally, where is he, and what are some of the other factors that might be contributing to this change.
We have a few more questions from people joining us on Facebook. Michelle asks, do you typically use, I may not be pronouncing this right, Concerta with Strattera?
So Concerta is a form of long-acting methylphenidate. So it's a standard stimulant that we use all the time. I think it's a very good medicine. Strattera is the non-stimulant medicine for ADHD. I typically don't use them together because I typically try to avoid two medicines doing the same thing. And so, I'd probably avoid using two antipsychotics together. I'd probably avoid using two stimulants together unless there was some reason for timing of the medicine. Concerta and Strattera are addressing ADHD symptoms through different neurochemical pathways, though. So there might be some rationale for doing that. Overall, I haven't done it very much. There have been some instances in which I'm switching a patient from one medicine to the other, especially if somebody's having side effects with stimulants, and we want to try to use Strattera. But Strattera is going to take 2 months to work. So in the meantime, I keep them on Concerta or a stimulant, and so that then we can see if that combination is doing anything. Typically, because I'm trying to switch, then after 2 months I'll take away the Concerta and see if the Strattera is doing anything. But very infrequently there have been these situations where the parents tell me that it actually worked better when the child was on both. Occasionally has happened when I've had kids on two antipsychotic medicines. So, as a rule, I generally don't use two medicines in the same class, but these weird situations do arise where I might stick with it because the family says it works better.
Great, thank you. Dawn asks, how do you suggest dealing with self-injury? The example she's thinking of is someone who's hitting himself mostly in appearance of frustration, not always with a discernible cause.
I think the place to start is doing whatever you can to determine if there is a cause that leads to a point of intervention. So that sounds to me like a much broader question, hopefully, than just a medication solution. So it's about trying to understand the purpose of the behavior, without knowing more, it's hard to be much more specific, but a very common factor in that circumstance is difficulty communicating, whether it's feelings or experiences or preferences, and so often facilitating communication around what's going on with that child in whatever way they're capable can lead to information that allows you to identify interventions. There's a limited role for medications in specifically treating self-injury. As Howard mentioned, there's many, there's scenarios where different medication classes might be helpful depending on what pathophysiologic components play into that injury, or that the point of getting to self-injury, whether it's anxiety and being overwhelmed, whether it's low frustration tolerance and poor impulse control. You know, there are a number of scenarios where different medications might help with that, but it's really about learning or doing some detective work and figuring out where the behavior is coming from and what purpose it's serving.
Yeah, I agree with Dr. Kamenish, and Dr. Kwan mentioned earlier that talking is sort of the state of the art still in psychiatry, and that's where I would start here, right? You want to know exactly before you settle on a medicine, because these medicines work better for certain symptoms than others, right? That's part of the art of what we do. We want to figure out what's driving that behavior. Like if that behavior is arising from a bedrock of anxiety, maybe there are some compulsions that the child is engaging in, and the self-injury is happening when that child is being prevented from doing those things. Well, that's going to be a lot different than if it's arising spontaneously or seemingly spontaneously.
Yeah, I guess one thing which we probably all assume but didn't really spell out and say, figuring out what's driving that type of behavior, what's behind self-injured behavior, is actually not an easy task, and usually requires a trained professional, somebody like behavioral therapist or psychologist, and many hours, and sometimes finding the person who's going to help you with that, or finding the way how to do it is actually, takes time, and it's not easy to find right type of people. So it's, but on the other side, that seems to be the most likely road to success in understanding behaviors and helping with decreasing those behaviors. So it's a hard route, but it's one which one needs to try to embark on.
And potentially identifying roles for non-medication interventions. We're always looking for opportunities for using therapies and behavioral interventions to treat symptoms as we see it, and we use medications when oftentimes when we feel like there's not a better alternative.
We are almost done for the time, but before we finish, there's one frequently asked questions from our families and colleagues about the use of medical marijuana and CBD and THC. What if they have any role in autism spectrum disorders? I also want to ask our panelists and Dr. Kwan if they have any thoughts about this.
Yeah, I can answer that a little bit. So my family subscribes to 3 magazines at home, and 2 arrived this week, and both of them had a feature on cannabidiol or CBD. Apparently there are bath bombs now made infused with CBD. So this is definitely a hot topic. CBD is cannabidiol. It's one of the substances that can be derived from the marijuana plant. THC is the psychoactive component of cannabis, and cannabidiol is non-psychoactive. There's a lot of interest in cannabidiol right now. I think the field as a whole recognizes that THC is not great for young people's brains, but especially our kids on the autism spectrum. Cannabidiol, though, there's a lot of interest in that. Whenever there's sort of the new thing, the market is always faster than the science. So you can find CBD all over the place. So, but do we have science to back up its use? Well, not the sort of placebo-controlled randomized trials that are our gold standard for determining whether something works and whether something is safe. The two questions that we always are thinking about. There have been a couple of sort of anecdotal studies of small numbers of using CBD in various formulations in the autism population that show that it might have some benefit for aggressive behavior, for hyperactivity, for sleep, and for anxiety. We'll see. But we also recognize that about over 50% of the families that come see us, have tried what we call complementary approaches, complementary medicine approaches. And there's a good reason for that. I mean, our tools, our medication tools are limited. So I'm always curious to learn more about sort of the new thing when it comes out. Here's what I know. So about efficacy, I told you, we don't really know much yet. For safety, there are some concerns with drug-drug interactions with CBD. In the sense that our bodies metabolize substances that we ingest in different ways. And sometimes if you have two things happening at once, that the metabolism of one can affect the metabolism of the other. And that's not always a good thing. So CBD does interact with some of the other psychiatric medicines that we prescribe. So that's the first thing that I want you to be aware of. The second thing is, as best as possible, try to figure out what you're buying. And that's harder than it looks. So it's not regulated, so we don't know for sure. But try to look at and see if they give you a milligram amount per dose. Okay, and you can bring that to your doctor, and that at least gives us something to work from. And the other thing is look for something called a COA. It's called a certificate of analysis. There's some for-profit companies that that look at some supplements and other sort of non-regulated things that you can buy over the counter, and check to see if what they claim is in it actually is in it. So it's not perfect. It's not government regulated, but that's a place I think to start.
Thank you all for joining us.
Thank you.
Thank you.